I said something about the thiazide diuretics, and its mechanism of action is by increasing sodium and water excretion. However, for the loop diuretics, it acts by blocking sodium and chloride reabsorption in the kidney, and even helps
Alex.
it even helps in patients with poor renal function. Okay, so loop diuretics cause decrease renal vascular resistance and increase renal blood flow. Like thiazides, they also cause hypokalemia. However, unlike thiazides, loop diuretics increase the calcium contents of urine, whereas the thiazide diuretics decreases it. These agents are rarely used alone to treat hypertension, but they are commonly used to manage symptoms of heart failure and edema. So we have amiloride and triamterene, which are inhibitors of epithelial sodium transport at the late distal and collecting ducts. And we have spironolactone and eplerenone, which are also aldosterone receptor antagonists. And they reduce potassium loss in urine. Like I said, potassium is needed by the body, but for you to lose it could also have an effect. So we have aldosterone antagonist, okay, which helps reduce potassium loss. And they have another benefit, which includes diminishing the cardiac remodeling that occurs in heart failure. So we move on to the beta adrenal receptor blockers. Please, my focus is much more on the drugs, okay? Like I said, if I don't change my direction towards that, we may not finish. The pathology part can take almost everything. So I have explained some of the basic ones which we would want to know about, okay, just to appreciate it. But questions would not come on any pathology that I will speak about, okay. So we have the beta blockers, okay, which reduces blood pressure primarily by decreasing cardiac output. And you remember I made mention of uh, beta receptors, which are located on our heart. So we have the beta one, which is mostly located on our hearts. And there are some drugs, which is propranolol, which can act on both beta 1 and beta 2. And since beta 2 is not really needed here, our focus is on the heart. We have selective drugs such as metoprolol and atenolol, which are selective blockers for beta 1 receptors. Okay. And here we also have an additional drug, which is nebivolol. And what it does is that it increases the production of nitric oxide. Now, nitric oxide plays a role in vasodilation. So here the blood vessels and everything is, a little bit expanded a bit, okay, so that blood pressure will be reduced. But it functions via the increase in production of nitric oxide. We also have the non-selective beta blockers such as the propranolol as mentioned above and nadolol, okay. However, they are contraindicated in patients with asthma due to the blockade of beta 2. And I said something. Level 400, I'm so sorry. We've spoken about beta 2. And just for you to have some feel of it, mostly beta 1 is located on our heart because your heart is only one. and beta 2 is located in your lungs because you have two lobes of your lung, okay? Just a way to help you remember. Uh, and in sympathetic arm, the beta receptors and alpha receptors are, stimulated, okay, to give a response. Now, once the beta 2 is in your lungs and you need energy to run away from whatever organism that you've seen, because sympathetic arm is always about flight, running away. Now, to run away, you need oxygen. You need to breathe in more oxygen. And before you can breathe in more oxygen, your beta 2 receptors has to bind to an agonist. Okay. And when it binds to an agonist or agonist, what it happens is that it causes your lungs to relax so that you can receive more oxygen. Because you need more oxygen to help with respiration and to increase your energy level so that you can run away from whatever organism you are seeing. Okay. By blocking this beta 2, it means that you are not going to, it means that your lungs are no more going to be relaxed, they'll rather constrict. So here in this case, it's not even good for asthmatic patient because in asthma, these patients require more oxygen. They require breathing. But you blocking beta 2, you are not allowing intake of oxygen, okay, or intake of air, sorry, in them, and that could exacerbate their condition. Please know that beta blockers should be used cautiously in the treatment of patients with acute heart failure too as well. Okay, so here, aside everything, please make sure you give selective blockers of beta 1, except of course, maybe the person is not asthmatic. Okay, so if the person is not asthmatic, then that possibility of administering selective blockers. Okay, so here is some of pharmacokinetics, the beta blockers. And like I said, our main focus is mostly on the pharmacokinetics and pharmacodynamics of the drugs. So if you know what pharmacology is, for the pathology side, is just to help you know where and when to administer a particular drug. But unfortunately, the pathology side has already been taken. Okay, so questions you should have asked in pathology, you are asking me in pharmacology. Okay, and I don't know. So please, bear with me. My style of slide presentation is now going to change a bit, okay, to help us complete these topics as fast as possible. So beta blockers are orally active for the treatment of hypertension, and we have propranolol, which mostly undergoes first pass metabolism. Please, if you've done pharmacology 1, you should know the role of first pass metabolism on drugs. And also we have these oral beta blockers, which may be taking several weeks to develop their full effects. So here, if you've learned something about loading dose, course, you should be able to understand this statement. Now, there are other forms of, formulation. Okay, so we have esmolol, metoprolol, and propranolol, okay, which can be given intravenously. And if you've learned intravenous formulation in pharmacology 1, this should be easier for you. So let's come to the adverse effects. So beta blockers may cause bradycardia. And like I said, you should be very careful when using beta blockers in heart failure, because for heart failure, I explained it in class that it's just like we going to the gym, especially the guys. Now the ladies are also joining us in our gym. Now for the guys, you can realize that as you raise a metal, okay, you keep on, especially dumbbells, okay, you keep on, extending and contracting your arms. In that case, you realize that your biceps, becomes hardened. Your biceps and triceps becomes so hardened. Okay, he said that even when you are trying to bath and you are raising your hand, you find some form of difficulty in even raising up that arm. That same thing occurs with the heart failure. That means your heart has been pumping. Your heart is a muscle. So as it contracts, relaxes, it's a way of you also, just like the way we gym, raising the dumbbell, bringing it down, raising it, bringing it down. And in that case, then now the muscles become so hard. Now before the heart can pump blood, okay, throughout the blood vessel, it requires a higher force to compress the muscles in the heart. I hope it's clear. And in that case, uh, 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 using a beta blocker there would rather reduce cardiac output, and the heart failure is even finding it difficult to push blood throughout your body. And you've added beta blocker. So normally it's very, very dangerous to do that. Okay. So when treating hypertension and the person has heart failure, you exercise caution when administering said drugs. Now, obviously, there is hypotension, and when there is hypotension, like I said, your blood will therefore not be able to flow to other areas, and therefore you can collapse. And it also has some effects on our CNS, such as fatigue, lethargy, insomnia. And you all know what insomnia does. Lack of sleep. Also, there is decreased libido and a cause of erectile dysfunction. So when that happens, men obviously are at risk of this embarrassment, especially, we men need this function for something important. And when you can't execute that function, then of course you would have to lay off these drugs, and therefore you stop taking the drug, because when you take the drug, you can't perform. In that case, it has a severe impact on patient compliance. I hope this point one has been well explained. Now for the question two, the non-cardio selective beta blockers have also been reported to decrease high density lipoprotein and increases triglycerides. Also, abrupt withdrawal may induce angina, myocardial infarction, and even sudden death in patients with ischemic heart disease. Okay, so here are some of these adverse effects. And I was asking these our the other time that what is the difference between side effects and adverse effects? And up to now, I've not received an answer. But I know on the D-Day, where we will all take the exams, you answer. You answer it for me. Okay. So now, someone asked the question on the angiotensinogen. Okay. And I said something about uh, 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 the drugs instead, because I told you that it will come in the subsequent slides. So please, anytime I'm presenting, I would like to take questions at the end of the class, because for all you know, I've already addressed your question. Okay. So here, but like I said, my focus is more on the drugs, not the pathology aspect. I won't ask questions on angiotensinogen. I'm asking about the drugs. So please don't go and learn pathology, because on that day, you will see stars. Learn the drugs instead. Okay, so the ACE inhibitors, and you know what ACE means, angiotensin converting enzyme. So these inhibitors are designed to block the activity of angioconverting enzyme, which converts the angiotensin 1 to angiotensin 2. Okay, and we have ARB, which is the angiotensin 2 receptor blockers. And you know what kind of drugs we give. Hmm? The blockers, Satan. You know, it's only Satan that blocks your destiny. So remember that. Okay. So these drugs blocks the enzyme and lowers blood pressure by reducing peripheral vascular resistance without reflexively increasing cardiac output, heart rate or contractility, sorry. So here, you know, like I said, whenever there is a reduction in blood pressure, okay, or there is a low blood pressure, that cardiac arm, there is baroreflexes and also the RAS, which is the renin angiotensin aldosterone system. They are triggered to increase your cardiac output. Okay, but these drugs can easily block without causing the reflex of increasing the cardiac output. So here we have the angiotensinogen, and we have renin converting this angiotensinogen to angiotensin 1, and we have ACE. So please, there are, for the renin inhibitors, remember I mentioned the drug. With the ACE inhibitors, there is also drugs for that. With the ARVs, there is also drugs. With the aldosterone, the conversion of angiotensin 2 to aldosterone, there is also aldosterone receptor antagonist to block that activity. And when that happens, there is reduced retention of sodium and water. There is also vasodilation of vascular smooth muscle, and also reduce output of sympathetic nervous system. And overall, together, it helps reduce blood pressure. So for the angiotensin converting enzyme inhibitors, the pharmacokinetics, they are orally bioavailable. We have drugs like captopro, lisinopril, okay, which undergo hepatic conversion to active metabolites. We have fosinopril, which is not eliminated primarily by the kidneys, but undergoes hepatic first pass metabolism. We have enalapril, which is also available intravenously. Now we have some of the side effects, which include dry cough, rash, fever, altered taste, hypotension, and hyperkalemia. Also, ACE inhibitors can induce fetal malformation and should be used cautiously in pregnant women. Please remember, I said it should be used cautiously in pregnant women. What drug did I say? I said ACE inhibitors. Okay, so you should expect a question from this. Now we move on to angiotensin 2 receptor blockers. And obviously they are blockers. So you consider the statins. Now, these drugs blocks angiotensin 1 receptor, decreasing the activation of angiotensin 1 receptors by angiotensinogen 2. Now, their pharmacologic effects are similar to those of ACE inhibitors in that they produce arterial and venous dilation and blocks aldosterone secretion, thus overall, reducing blood pressure and decreasing salt and water retention in the body. Now, these agents are also teratogenic. So consider that they are teratogenic. And so please know the difference. One causes malformation. The other one is teratogenic. So if I ask a question, if I mention teratogenic, the keyword, then of course, you should consider angiotensin 2 receptor blockers. And this should not be used by pregnant women. Now, we have the aliskiren, which is renin inhibitor. So they block renin from converting angiotensinogen to angiotensin 1. And here, they act directly to inhibit renin. Okay, so for it, it blocks it from the beginning, and that cascade of the renin-angiotensin system is being blocked. Okay, so it comes earlier, even before the angiotensin converting enzyme inhibitors or the angiotensin 2 receptor blockers. However, there is some price you will pay selecting aliskiren for treatment. It can cause diarrhea, especially at higher doses, and also cause cough and angioedema in the body. And aliskiren is metabolized by CYP3A4. I hope you've all done phase 1 and phase 2 enzymes. This is pharmacology 1. So if you don't understand, then it means that you have to join pharmacology 1 again. If you had an A, then it means that your A is questionable. All right, so please, this is just a summary. Normally, at the end of the class, I give summary or whatever is going on. So we have the angiotensinogen coming out from the liver. We have the renin, which is mostly found in the kidney. And we have the inhibitors, aliskiren, blocking the activity of the renin. Also, we have the ACE inhibitors, which has to block the angiotensin converting enzyme. And here, you see what the ACE inhibitors does. Yeah? The increase in bradykinin, okay, is broken down. And wherever bradykinin is an otacoid. And this is taught in pharmacology 1. If you didn't do pharmacology 1, then I don't know, you have to join that class again. But it's an otacoid. And here, what this means is that this bradykinin causes vasodilatation of blood vessels. But this ACE or angiotensin converting enzyme breaks down this bradykinin. So obviously your blood vessels will remain constricted. I hope it's understandable. So to prevent that, we have inhibitors against the angiotensin converting enzyme. Now, we have the angiotensin 2 receptor blockers. And like I said, they are satans. And please, I didn't say Satan, Satan. So we have losartan, candesartan, valsartan, okay? For them, they act at the blocking aspect. So when the angiotensin gets there, oh, they already occupy there. And therefore, it prevents aldosterone release. All right, so we move on. And you know the function of aldosterone causes constriction of blood vessels. So that arm is curtailed, okay, with the help of the statins. Now, for the calcium channel blockers, so we have some origins. Normally, it can be classified in 3 chemical classes. So we have the diphenyl alkylamines. An example is verapamil. We have benzodiazepines. Example is diltiazem. we have dihydropyridines. An example is nifedipine, amlodipine, felodipine. Please, they function on only calcium. So you can't give only one drug and expect a patient, a hypertensive patient to be okay. Okay, you have to target various pathways. If you want to target the renin path, you give aliskiren. If you want to block the beta receptors, you should remember, are you trying to selectively block or non-selectively block? If you want to selectively block, then you consider metoprolol. If you want to do it general, consider propranolol. Hey, Clement, you started your thing again, eh? Let me see how to. There's a way to off this annotation thing. This, I'm sorry, it's because someone has decided to write on the slide. What am I doing? I've forgotten how to do this. Clement, your last one. I've forgotten how to do this. All right, let's move on. So the mechanism of action is that this calcium channel blocks the influx of calcium by binding to the L-type calcium channels in the heart and in the smooth muscle of the coronary and peripheral arteriolar vasculature. Now, this causes vascular smooth muscle to relax, dilating mainly the arteries. Please remember that the calcium channel blockers do not dilate the veins. Now we move on to the pharmacokinetics. So initially, I used to give the pharmacodynamics and kinetics of each drug. But after I met Mausi, Mausi suggested that I should try as much as possible to do it in a group. Current studies are still ongoing on some of these drugs. Wow, I have 10 minutes. Okay, so please let me move faster, okay? So most of these drugs have short half-life following an oral dose, and then you should always remember that there is always a sustained release preparation, and this permits one's daily dosing. Now we have amlodipine, which has a very long half-life and does not require a sustained release because amlodipine has a long half-life. It means that when it gets into your system, it's not easily excreted. So please remember some of the side effects here. We have peripheral edema, we have hypotension, we have headache, we have dizziness. So I've summarized that here. Okay, and note that nifedipine and other dihydropyridines may cause gingival hyperplasia. Now we move on to the alpha adrenoceptors blocking agents, 946. They decrease peripheral vascular resistance and lower arterial blood pressure by causing relaxation of both arterial and venous smooth muscle. Actually, I've taught them what alpha and the role of alpha and beta, okay, earlier in our autonomic nervous system. That's why I'm reading throughout, okay, because I've already taught them. But for the level 400, we will start everything afresh. So you take your time, you get to know, okay. So some of the drugs include prazosin, doxazosin, and terazosin, which may cause reflex tachycardia and or postural hypotension, okay. We have labetalol and carvedilol, which blocks alpha 1, beta 1, and beta 2 receptors. So carvedilol and metoprolol, succinate, and bisoprolol is mainly used in the treatment of heart failure. Conversely, labetalol is used in the management of gestational hypertension. So please, we'll talk about that another time. So level 3, and I will be meeting you guys tomorrow. Okay, so we'll talk more about it. For the centrally acting adrenergic drugs, there are drugs which acts, on our CNS. So we have clonidine, which acts centrally as an alpha-2 agonist to produce inhibition of sympathetic vasomotor centers. And here it decreases sympathetic outflow to the periphery. The clonidine is absorbed well after oral administration. So I'm describing the pharmacokinetics here. I didn't indicate that. And it's excreted by the kidney. It can also be given via the transdermal patch. Okay, so that's we've got the anterior route and the parenteral route. That's pharmacology 1. So try to understand that. So we also have adverse effects of this clonidine, which includes sedation, dry mouth, and constipation. And it can precipitate a hypertensive crisis after cessation. We also have the methyl dopa, which is also an alpha-2 agonist. So please, clonidine, methyl dopa, they are all alpha-2 agonists. And how is it gotten from? So it's converted from methyl norepinephrine. Okay, so it's converted to methyl norepinephrine, and it acts on the adrenergic receptors to diminish the adrenergic outflow from the CNS. And some of the most common side effects include sedation and drowsiness. So how many more slides? Okay. So we also have the vasodilators. They direct they directly act on smooth muscle, and they act as relaxants. Okay, so some of these drugs include hydralazine and minoxidil. Most males actually use the minoxidil for treatment of beard, for the growth of beard. So those beard gang people, they apply minoxidil, but little do they know that this minoxidil can cause hypotension. So a guy will be there with full grown beard, and you can just collapse just because the hypotension has set in. Okay, so this produce reflex stimulation of the heart, resulting in the competing reflexes of increased myocardial contractility. Okay, and here there is an increase in heart rate and oxygen consumption. Please, whenever I say reflex, it means that whenever your body always try to counter an activity. So if you are sweating, it's because you are doing something which is producing heat. So the body has to produce water to calm down your body temperature. Likewise here, when your blood pressure is low, there is a reflex stimulation of the heart. Okay, and this increases your heart rate as well as oxygen consumption. And this action may prompt angina pectoris, myocardial infarction, or cardiac failure in predisposed individuals. Okay, so we have the hydralazine, which is used in pregnancy, induce hypertension. So please remember this: hydralazine is used in pregnancy, induced hypertension, and mostly is accompanied with a beta blocker such as propranolol, metoprolol, and atenolol to balance the reflex tachycardia, and a diuretic to decrease sodium retention. Now, together, the 3 drugs can help decrease cardiac output, plasma volume, and peripheral vascular resistance and in pregnant women. Okay. So some of the adverse effects include headache, tachycardia, which is a reflex mechanism, nausea. Please, yeah, we will treat that for the level 400. Nausea and vomiting, which one precedes the other. And sweating, arrhythmia, and precipitation of angina. Also, you have a lupus-like syndrome, okay, which can occur at high doses, but it is reversible when you stop taking the drug. Also, minoxidil can cause hypertrichosis, which is the growth of body hair. And like I said, is used by these beer gang people. So you have hydralazine here, minoxidil here. We've already spoken about them. We also have the phenol-dopam. Okay, it acts on dopamine receptor, and this causes dilatation. Okay, we also have nitroglycerin, which also increases nitric oxide to, expand or cause dilatation of blood vessel. Also, we have bosetan. And bosetan also allows your airways to dilate, okay? And they act to block endothelin 1, which causes constriction of this um, airway, narrowing of this airway. So today, that's the end of our topic on uh, hypertension. Please, do you have any question? Please, do you have any question? Okay, since we don't have any question, uh, level 300, I'll be meeting you tomorrow and we'll continue the rest of the section under cardiovascular pharmacology. However, level 400, uh, I was told that I'll be meeting you on Tuesdays, Wednesdays, and Thursdays, but I will include Friday for you so that you can catch up with the level 300s as well. Please, I hope it's fair.
Yes, please.
Yeah, that's all right.
Please, this is not how I teach physically, because physically, normally I write on the board, but with uh, this Zoom thing, do you really get it? Do you really understand whatever I've taught so far? Is it clear?
Yes, sir. It's clear. It's
Yes,
clear.
it
Sorry,
is.
it's
I've got,
clear.
I've gotten the.
Yes, sir. It is very, very clear.
Okay, okay. So I'm glad. My aim is for you to understand. So once the understanding is there, you can
This
easily
new
grasp
slide
the
is fantastic.
Okay. All right.
Yeah,
So
sir, I have a question.
yes,
I have a
please.
question. Yes, sir, I have a question. Yeah, so the class for level 400, is it going to be on Zoom? Can some of the level 300 join? At least